Welcome to this episode, where we're diving deep into the pituitary gland's role in pediatric endocrine disorders. The pituitary, often called the master gland, really orchestrates a complex hormonal symphony that affects growth, metabolism, fluid balance, and sexual development. Today we're unpacking hypopituitarism, hyperpituitarism, precocious puberty, and posterior pituitary disorders like diabetes insipidus and SIADH. It's a lot to cover, but these conditions have profound clinical implications, especially in children.
Absolutely, Liam. The pituitary's influence is so broad, and its dysfunction can present in such varied ways. I think it's crucial we start by framing the endocrine system itself, how it's essentially a messaging network, with hormone-producing cells sending signals, target organs receiving them, and the bloodstream acting as the delivery route. The anterior pituitary secretes tropic hormones that regulate other glands, while the posterior pituitary releases hormones like ADH and oxytocin, synthesized in the hypothalamus.
Right, and when we talk about pituitary dysfunction, it can be due to organic causes like tumors or trauma or idiopathic origins. The anterior and posterior lobes have distinct hormone profiles, so the clinical picture depends heavily on which hormones are affected. For instance, hypopituitarism involves diminished secretion of one or more anterior pituitary hormones, and panhypopituitarism is the loss of all anterior hormones, with the posterior lobe usually intact.
That's a good point. The clinical manifestations really hinge on the specific hormone deficiencies. For example, growth hormone deficiency leads to proportional short stature, delayed bone age, and delayed epiphyseal closure. Interestingly, these children often have increased insulin sensitivity and may show premature aging later in life. Then, thyroid-stimulating hormone deficiency manifests as classic hypothyroid symptoms: dry, coarse skin, cold intolerance, bradycardia, and delayed dentition.
And don't forget gonadotropin deficiency, which results in absent sexual maturation, genital atrophy, amenorrhea without menopausal symptoms, and decreased spermatogenesis. Adrenocorticotropic hormone deficiency is particularly serious, with signs like severe anorexia, weight loss, hypoglycemia, hypotension, and electrolyte imbalances that can precipitate adrenal apoplexy, especially under stress.
Exactly. And while ADH deficiency leads to polyuria and polydipsia, causing dehydration, melanocyte-stimulating hormone deficiency results in decreased pigmentation. The most common organic cause of hypopituitarism is a tumor in the pituitary or hypothalamic region, especially craniopharyngiomas. Congenital hypopituitarism can present in newborns with apnea, cyanosis, severe hypoglycemia, and seizures, often suggesting a genetic basis.
The idiopathic form, often related to GH deficiency, is a bit trickier. It causes growth failure defined as height below 2 standard deviations for age, or a growth velocity consistently less than 1 standard deviation. But it's important to differentiate this from familial short stature or constitutional growth delay, which are more common and benign.
Right, and that's where diagnostic evaluation becomes critical. A thorough family history, growth patterns, physical exam, psychosocial assessment, and radiographic imaging like MRI and bone age X-rays all play a role. Endocrine studies, including GH stimulation tests using agents like clonidine or arginine, help confirm GH deficiency. Serum IGF-I and IGF-BP3 levels are useful screening tools.
The bone age assessment is particularly interesting. A delayed bone age suggests potential for catch-up growth since the epiphyseal plates remain open, whereas a normal bone age in a short child is more concerning and may indicate a less reversible condition. So the skeletal maturity gives us insight into prognosis and treatment timing.
Speaking of treatment, GH replacement therapy is the cornerstone for GH deficiency, especially when caused by organic lesions. Biosynthetic GH is administered subcutaneously, ideally at bedtime to mimic the natural nocturnal surge. Growth velocity typically increases in the first year, then slows, but early intervention is key to optimizing final height, even though it may not normalize completely.
And while on GH therapy, monitoring for hypothyroidism and adrenal insufficiency is essential, since these can develop as associated deficiencies and be life-threatening if unrecognized. Replacement of other deficient hormones, thyroid extract, cortisone, sex steroids, is also necessary to support normal development.
The nursing role here is multifaceted. Identifying children with growth delays through accurate measurement and history is fundamental. Nurses also support families during diagnostic testing, which can be stressful and involve risks like hypoglycemia during stimulation tests. Education on GH administration, injection techniques, and adherence is vital, as is psychosocial support to help children cope with delayed growth and development.
That psychosocial aspect can't be overstated. Children with GH deficiency often appear younger than their chronological age, which can affect self-esteem and peer interactions. Nurses and families need to set realistic expectations and emphasize abilities and strengths rather than physical size, promoting a positive self-image.
Shifting gears to pituitary hyperfunction, oversecretion of GH before epiphyseal closure causes gigantism, proportional overgrowth of long bones, sometimes resulting in heights over 2 meters. After epiphyseal closure, excess GH leads to acromegaly, characterized by transverse bone growth, enlarged facial features like the jaw and tongue, thickened skin, and dental malocclusion.
Pituitary adenomas are the usual culprits here. Clinically, children may present with headaches and signs of increased intracranial pressure. Diagnosis involves history of excessive growth, elevated GH levels, and MRI findings of a tumor or enlarged sella turcica. Bone age is typically normal, which contrasts with GH deficiency.
Treatment is primarily surgical, cryosurgery or hypophysectomy to remove the tumor. Radiation or radioactive implants may be adjuncts if surgery is incomplete. Pharmacologic agents that suppress GH secretion are also used. Post-treatment, hormone replacement may be necessary if pituitary insufficiency develops.
From a nursing perspective, early identification of excessive growth rates is crucial. While medical management can't reverse growth already attained, it can restrict further growth. Emotional support is equally important, as children with gigantism or acromegaly may feel isolated or self-conscious, especially before adolescence.
That's a good segue into precocious puberty, which is traditionally defined as onset of secondary sexual characteristics before age 9 in boys and 8 in girls. However, recent data suggest puberty onset is occurring earlier in some populations, especially girls, which complicates the definition.
Right, and there are 2 main types. Central precocious puberty, which is GnRH dependent and involves early activation of the hypothalamic pituitary gonadal axis, and peripheral precocious puberty, which is GnRH independent and caused by hormone secretion from gonads, adrenal glands, tumors, or exogenous sources.
Central precocious puberty accounts for about 80% of cases and is more common in girls. Causes include idiopathic origins, CNS anomalies, infections, trauma, or tumors. Peripheral precocious puberty includes conditions like familial male-limited precocious puberty, Albright syndrome, and congenital adrenal hyperplasia.
Diagnosis involves clinical assessment and imaging to identify CNS lesions. Treatment for central precocious puberty uses GnRH analogs like leuprolide acetate or histrulin implants to suppress pituitary gonadotropin secretion. This halts or regresses secondary sexual characteristics and normalizes growth velocity.
Treatment is discontinued at an appropriate chronological age to allow normal puberty to proceed. Nursing care focuses heavily on psychological support and education for the child and family, including teaching injection techniques and setting expectations. It's important to reassure families that despite physical changes, the child's mental age aligns with their chronological age.
Now, turning to posterior pituitary disorders, diabetes insipidus is the principal hypofunction disorder caused by ADH deficiency leading to uncontrolled diuresis. The cardinal symptoms are polyuria and polydipsia, with enuresis often being an early sign.
In infants, irritability relieved only by water feedings, dehydration, electrolyte imbalance, and even circulatory collapse can occur. Diagnosis involves fluid restriction tests, where in DI urine remains dilute despite dehydration. Response to vasopressin injection helps differentiate neurogenic DI, which is responsive, from nephrogenic DI, which is not.
Treatment is with desmopressin, a synthetic ADH analog, administered intranasally, orally, or parenterally. It's a lifelong therapy, so education on medication administration and emergency preparedness is critical. Nurses play a key role in early identification, monitoring fluid balance, electrolytes, and weight, and educating families and schools to ensure unrestricted bathroom access.
That last point is so important. Denying bathroom access can lead to embarrassing accidents and school refusal. Also, children with DI complicated by congenital absence of the thirst center need encouragement to drink enough fluids to prevent electrolyte imbalance.
On the flip side, syndrome of inappropriate antidiuretic hormone secretion, or SIADH, results from excess ADH causing water retention, hyponatremia, and hypotonicity. It's common in CNS infections, tumors, or trauma.
Symptoms range from nausea and irritability to severe neurological signs like seizures when sodium drops critically. Management centers on fluid restriction tailored to severity, monitoring for fluid overload, and seizure precautions. Nursing care involves vigilant intake and output monitoring, weight checks, and family education on fluid restrictions and symptom recognition.
Rarely, chronic SIADH requires long-term ADH antagonists, which adds another layer of complexity for families and nurses. Recognizing early symptoms like nausea and malaise is key to preventing progression to severe neurological complications.
To wrap up, the pituitary gland's role in regulating multiple endocrine axes means its dysfunction can manifest in diverse and complex ways. Early diagnosis, multidisciplinary management, and comprehensive nursing care are essential to optimize outcomes.
And beyond the clinical, the psychosocial impact on children and families is profound. Supporting them through education, realistic expectations, and emotional guidance is just as important as the medical treatment.
Exactly. Understanding these nuances helps us provide holistic care that addresses both the physiological and psychological needs of pediatric patients with pituitary disorders.
Thanks for joining us in this deep dive. We hope this discussion sheds light on the complexity and importance of pituitary function in pediatric endocrinology.
Absolutely. Until next time.